All right, so this is joint work with um, with David Mitchell of the University of Central Arkansas. He's also at ACRE. So we're looking at how occupational licensing reform for nurse practitioners affects various health outcomes for children. So just kind of a brief history of nurse practitioners. So as a profession, they're fairly new. They began in 1965 in the state of Colorado, coincidentally with Medicare and Medicaid. So the whole purpose of having nurse practitioners was to deal with physician shortages. So we've been dealing with physician shortages for a long time. So nurse practitioners are advanced practice registered nurses. So as of 2020, based on the American Association of Nurse Practitioners, about 95% of them have an additional degree beyond a bachelor's. 17% of them hold doctorates. So the big issue with nurse practitioners is how substitutable are they with doctors, primary care physicians to be more precise. So Kaiser Permanente says that, a nurse practitioner can perform 80 to 90% of the tasks that a physician can perform, a primary care physician can perform. And despite, we might disagree on what percent of the tasks that they can perform, there's clearly some idea that there's some substitutability between nurse practitioners and primary care physicians. So the other big thing about nurse practitioners is, supporters of restrictions point out that, the reason we have restrictions on nurse practitioners is to maintain quality of care. Opposers point out that, you don't actually need to have these occupational licensing restrictions. So a paper with Connor Norris, not a paper, but a brief with Connor Norris and I show that you can kind of overcome this big criticism of occupational licensing through voluntary certification. And for nurse practitioners, there is a board certified voluntary certification program. All right, so you have a mechanism to sort out quality. So right now, there are about 290,000 nurse practitioners. So this is based as of 2020, and 66% are in primary care roles. I believe this is of the ACS, but there's 484,000 primary care physicians. So over the past 20 years, there's been a big increase in nurse practitioners. All right, so there's this idea that they might be substitutable with doctors. But in the US, there's considerable geographic variation. And what tasks a nurse practitioner can perform is determined by the state board. And it appears that this geographic variation is mostly idiosyncratic, probably motivated by public choice mechanisms as opposed to health-related or quality mechanisms. So most of the scope of practice restrictions I would class them into two kinds. So there's prescriptive authority. In certain states, what nurse practitioners can prescribe is limited. They have to use their doctor's pads. And the other area I would say is independent practice authority. So there's lots of variation in what a nurse practitioner can do. In certain states, even like the level of supervision is very extreme. The physician has to sign off on it. So in our paper, we're going to look at independent practice authority. So that includes prescriptive authority. So what happens when states allow nurse practitioners to function as primary care providers without many restrictions? So as you can see, I believe this is based off 2012. There's considerable geographic variation. And if it's idiosyncratic, what we want to do is we want to look at how when states change occupational licensing for nurse practitioners, this generates a nice counterfactual. And that lets us see whether, whether this geographic variation makes any sense, if we should have any restrictions or not. So that's kind of the plan in the paper, to exploit changes in occupational licensing to look at whether whether the licensing has any positive effects at all or not. So why is the scope of practice for nurse practitioners an important topic? Nurse practitioners are growing at an increasingly fast rate. So this is so while this is only till 2008, even since then, they've grown at a very fast rate. So nurse practitioners are growing at around 9%. Physicians grow at 1%. The number of NPs has doubled between 2007 and 2020. So when we talk about healthcare markets, this is one area where the supply has increased considerably. And I was shocked by this. And the thing is, access to care is a very important topic. And whenever politicians or in the health policy sphere, people talk about access to care, they focus mostly on demand side. Let's increase insurance, or let's increase eligibility. But we might also want to look at supply side changes, so there's tons of stuff on the ACA, Medicaid expansions, but there's not much work on what happens when you actually have a supply side change. Another reason why I think this is an important topic is, if you look at that map, we still have 22 states that have restrictions. Either these restrictions are useful or they're not. So either we should all have them, all states should have them, or they shouldn't. So that's what we kind of want to ask. And another reason is, the American Association for Medical Colleges predicts a shortage of 50,000 physicians, so primary care physicians. So we have what's called a so-called predicted shortage. And if you were to break this down again by geography, the shortage tends to be higher in rural areas. So if nurse practitioners are high quality, then this is one way to address shortages, increase access to care. All right, so first I'm going to just talk about the broad literature. I've just chosen 4 good papers. So much of the research on nurse practitioners tends to look at cost, access to care, and quality. So Battaglio shows that nurse practitioners tend to spend more time with patients. So that's an important thing to keep in mind, because when we think about how these laws affect health outcomes, we generally think of them as improving supply, so that would be the first stage. But if nurse practitioners spend more time, they might also have better quality. So it's not just access to care, it might also be an improvement in quality. So Lenz has another paper that is a randomized controlled trial. Patients were assigned a doctor or a nurse practitioner, and Lenz finds no statistical differences in either patient outcomes or satisfaction. So this Lenz article is very important, because this tends to kind of confirm what the evidence is showing, is that at least even on the quality side, there doesn't appear to be significant evidence that suggests primary care physicians are better than nurse practitioners. So again, in motivating the first stage, Morris Kleiner finds that having independent prescriptive authority, independent practice authority, raises the number of hours worked for nurse practitioners, but has no effect on infant mortality. So those 3 articles tend to suggest, there's a improvement in supply, and even a no effect is a positive. So again, it suggests that, if you give nurse practitioners independent practice authority, they don't kill people, and I think that's a good thing. Ed Timmons has a very nice paper. Again, he's looking at the amount of what states are charged for Medicaid reimbursement. So he's actually looking at, I think, physicians assistants, and nurse practitioners, and he tends to show that the more nurse practitioners you have, the lower the state pays for Medicaid beneficiaries. So the important thing here, I think, is to keep in mind that even if you have no health, if you have no improvement in health, just having a null effect suggests that they don't harm people, and that's good enough to let them practice, because if they don't harm people, let them practice. All right, so I think there's divergence in the nurse practitioner literature. So if you look at more recent studies, they tend to find positive effects. And one of the reasons I think this happens is because, as I talk about, the supply of nurse practitioners is increasing at a much faster rate than primary care physicians. So now that we have a lot more nurse practitioners, when you actually allow them to practice, the bite of these laws is bigger than it was, say, 20 years ago. So a very nice paper is by Diane Alexander. So she's looking at prescriptive authority, and she finds that an expansion of prescriptive authority, so she's looking at between 1990 and 2014, improves mental health. So she's using the behavioral risk factor surveillance system. She finds that you see significant improvements in self-reported health. So people report they had fewer bad days of mental health. And also on mortality. So it's not just some subjective self-reported outcome. She also shows a decline in mental health related deaths, such as like suicides. So I think like that article, I think is very important to motivate the first stage. So even though you can't directly measure how nurse practitioners are directly affecting patient outcomes, I think that's a very important study. We have Udalova, who also looks at independent practice authority. So again, no net effect on usage, but they seem to find a substitution. Less usage of emergency departments and more usage of primary care. So you might not see any changes on whether it's how many visits that people make, but they are substituting from more expensive care to less expensive care. Again, that's another Journal of Health Economics article. So Stanja uses MEPS, finds prescriptive authority has minimal impact on utilization, prescription prices. So Groover again uses MEPS, and she finds that nurse practitioners tend to reduce the number of prescriptions that patients get. So she suggests that even though here we see like care going down, but it's in a good way because nurses are using more nurse practitioners results in them, simplifying prescriptions and not giving a lot of prescriptions.
Morris Kleiner has a clarifying question for you. What about physician assistants versus nurse practitioners as a substitute for primary care physicians? How are they different in their scope of practice?
So I haven't looked at physician's assistants. That's one thing that I feel like we will have to look at because, the issue might be that, a lot of this nurse practitioner reform is correlated with what's going on with physician's assistants. So far, we only have data on nurse practitioners, but that's something that we do want to look at because I feel like that's another, we might be picking up that change also. So that's a very good question, and I have to look into that, or we have to look into that. All right, so our research question is we're looking at changes in occupational licensing, mostly expansion of independent practice authority, and how that affects access to care and health outcomes for children. So Morris Kleiner obviously has that piece on infant mortality. We're one of the first studies to look at the intermediate stage in life, so we're looking at children. So there's a bit of work on infants using vital statistics, and there's a lot of work on adults. So where we see this paper eventually fitting in is to look at how expansion of independent practice authority affects healthcare for children. The health outcomes literature is a bit more limited. There's tons of stuff on prices, labor market. So we see these two areas as a contribution to look at health and to look at children, which the research has not focused as much in the past. All right, so we're using a relatively underused study. So this is the National Survey of Children's Health. So this is a large repeated cross-section of American children aged 0 to 17. So these are all children who are not institutionalized. So these are children in homes, in normal homes who are not, who are in normal homes. So the NCHS was conducted over 3 waves. So there's one in 2003 and 2004, 2007, 2008, and 2011 and 2012. So they used random digit dialing. They reached out to households, and they asked in a specific household to usually the mother about the health of a selected child. So one child was selected from a household based on random digit dialing. And then they asked a lot of questions about the child's health, the family background, socioeconomic status, all that. So the nice thing about NCHS versus other health studies is that it sampled each state with 1,800 to 2,200 observations. So a lot of national studies won't have that many observations. So like, like my state of Arkansas, if you were actually to break down how many observations come from Arkansas, you generally don't have that many. So nice thing is that they weighted, not the weighted, when they sampled each state, in each wave they chose at least 1,800 to 2,200 observations. So that gives us a lot of power, especially when changes in occupational licensing affect in a low population state, where otherwise in another survey you wouldn't have that many observations. So again, a common criticism for these types of studies is that, we're relying on the parents to make assessments of the kids' health. So the idea is the doctor tells the parents, then the parents tell the interviewers. So that might, add measurement error. And certain evaluations like health status are based purely on what the parent perceives. So, that's a subjective variable. Another issue is with the way that the survey is conducted. So even though we have 2 years, most of the survey was conducted in like 1 year. So in 2011 and 2012, like 85% of the survey was done in 2012. So we don't actually have the year variable. So we're assigning the year where we had the most observations in the particular survey. So again, that adds measurement error. So those are some of the trade-offs that came with going with the NCHS. How do we get information on independent practice authority? So we looked at legislation from state nursing boards and state level legislation. We also went back and we looked at revisions. So whenever there was a revision to independent practice authority, we looked at what the revisions specified. And then we cross-checked that with the nurse practitioner data. So generally we have a significant overlap with earlier research, but because we went back and we looked at revisions, so like a couple of our years are a bit different than what other studies find. So we also pulled some bureau state level macroeconomic variables, unemployment rate, log of per capita income. We have log of population and the per capita healthcare spending. So just to look at, so just to kind of use these as controls to make sure that, we're accounting for the fact that, the state might change its level of spending.
Roy did have a comment and said that you can check if the measurement error is uncorrelated with the treatment group.
Yeah, I'll have to ask you more in once I'm done. Yeah, I'd be interested in following up. All right, so one of the things about children's health outcomes is you tend to see trends. So if you look at doctor's visits, as children get older, the number of visits are going down. It's actually not a big change, So when someone is 0 or a parent that has a baby, 92% of the parents say that the kid has a doctor. So as they get older to age 17, about 88% of the parents say the kid has a doctor. It's not really a big change, but you see a downward trend. Similarly, you see a downward trend in any visits. This should be total visits, and this is any visits, and an increase in prescriptions. All right. So we're looking at asthma. So talking about trends in children's diseases, generally, if you look at how diseases are diagnosed for children, you see an uptrend. So when kids are very young, you don't see lots of diagnoses. As the kids get older, diagnoses go up. So that's asthma, and here we have our learning disabilities, ADHD, medication for ADHD, bone injuries, autism, diabetes, and so forth. So generally, for children's ailments, we see that they tend to go up over time. So diagnoses go up over time. And if we were to break this down by socioeconomic status, you generally see African Americans having much higher rates of various ailments. And if you did it by socioeconomic status, you'll see poor kids having much higher ailments. All right. And lastly, this is subjective health status. So this is often used in the literature. So a lot of the child health inequality literature has used this 5-point variable, how parents perceive their kids' health, and this has been used to evaluate inequality in children over time. So Darren Lubatsky has a 2000 AER that looked at, the gradient in children's health, and that was based off of this 5-point subjective variable. So it's a subjective variable, but it's been used in the literature. So I see that as validating the literature. All right, so let's look at the descriptives. So asthma is the most common childhood disease. 14% of kids have asthma. The next biggest prevalence of disease is ADHD. About 8% of the kids have ADHD. So those are the high prevalence diseases. So what's our motivation? So this is the theory section. We're working on it. So we're going to use the health production function. So here you have health I for kid I at time t. Health depends on some endowments given by theta. Delta is the depreciation. So theta is the endowments. This is the health in the previous period times the depreciation. I is the investment in health, and investments in health depends on the price of medical care and non-monetary investments. So what's the mechanism between occupational licensing and children's health? So the first one we think is it lowers the price of medical care, literally because there's considerable evidence that suggests costs go down. The other thing is access. It might be a little bit easier to get access to medical care. Also, the quality of medical care might go up. So this is this section is a work in progress, but this has a lot of implications because what the child health literature says that is if you improve health in childhood, that will improve health in adulthood. So health has a sequential pattern. So if you improve health in childhood, it can improve future health, and it can also spill over to human capital outcomes. So that's our theory. The idea there is healthcare gets cheaper, parents consume more of it, that makes kids a bit healthier.
Morris would like to comment, if licensing's main purpose is to reduce downside error, can you look at malpractice insurance rates as a measure of quality for nurse practitioners?
Yeah, that's a good idea. Let me write that down. Thank you. All right, so we're using a diff framework, right? Two-way fixed effects, state dummy variables to pick up time invariant state characteristics, and your fixed effects to get common changes across states. So this is intention to treat, reduce form. So Y is our dependent variable. So Y is some outcome of interest. That's all the access to care and childhood ailments. We have our fixed effects. We have our parameter of interest, which is scope. So this is whether a state, so this is a binary variable, and this is whether a state expands independent practice authority. So in our vector X, we include age, sex, macroeconomic characteristics, healthcare spending, and some family background characteristics, the size of the family. So we do restrict our study to children age 2 and older, and that's because of the time trend that you see, or the trend by age that you see. For age, generally doesn't change results that much. All right, so our key identification assumption is parallel trends. So the biggest issue with this survey is we only have 3 periods. So we need 2 to do diff and diff, and we need 3 to put in a linear trend. But it doesn't allow us to do a lot more of the more validating stuff, like we can't do the event study. So even though while we do have subsequent waves to the NCHS, which we began in 2017, the survey completely changed its focus. So we only have 3 waves, and we can't pool additional information. So the 3 time periods are a limitation. All right, so still to kind of test out, to provide some auxiliary evidence for the diff and diff, we do put in state by cohort fixed effects. We do include a lead to test for a pre-trend. And all of our regressions are weighted by the sampling weights that the NSCH provides. We cluster our standard errors at the level of treatment. And then we also break down, we separately estimate our analysis based on the initial level of the supply of healthcare. So we look at how many physicians there were in 2003, and we break our sample into states that were above the median and below the median. And the reason we do this is because, the original initial allocation of nurse practitioners tended to be higher where there were physicians because there were a lot of restrictions. So we want to see how the initial supply of healthcare affects outcomes. So again, so the other issue is state level policies that are associated with independent practice authority. As Moiz has pointed out, there might be other things that are going on with physician's assistants. And we want to look at what's going on there. So maybe to either control for that or just to kind of look at that also. So that's a concern at this point of the paper, and that was a good point. All right, let's look at our outcomes. So if we look at a prescription, so this is a 0-1 variable, whether a kid has a prescription. If we look at scope of independent practice authority, we see no effects on prescriptions. One significant effect on states that were below the median, and it suggests a reduction. No effects on whether the kid actually has someone who they identify as a primary care provider. So we see negative signs for the number of visits, but we don't actually see a statistically significant effects. Very, very noisy. But if we were to break this down by any visits, we do see a significant effect, a 1.7 percentage point increase in the number of visits. And if we put in our state by cohort fixed effects, this is marginally significant, but still positive. Here we put in our lag. Here we put in a lead to test for the pre-trend. Again, we still get a significant increase in the number of visits. And when we break it down by our high and low states, we see the effect in high states. So overall, like earlier studies that look at nurse practitioners, we see modest effects on utilization. And on the one variable where we do see effects is whether the kid has had any visits. So this seems to be consistent with the earlier literature. So when we look at asthma, which is the most common illness affecting children, all across our specifications, we see a fairly big reduction of 1.5 percentage points. So one of the issues with asthma is sometimes kids don't use inhalers. So Zucchi has a nice paper that, this inhaler usage is correlated with socioeconomic status. So we feel like maybe access to care is improving, either kids being able to see a nurse practitioner or improving their treatment regimen. We can't quite separate that out right now. So we see a reduction in asthma, and we see an increase in severity. So what we think is going on is that, the marginal cases are being better treated. So once you actually pass independent practice authority, the remaining kids who do have asthma are the more severe kids. So we see that, so we think what's going on is the marginal cases of asthma are treated better with nurse practitioners. And one of the points of advocacy for allowing nurse practitioners to practice is that they're probably much better for treatment of chronic diseases like diabetes and asthma than primary care physicians, because you can get more access to them. So again, we see a reduction in the prevalence of asthma, but an increase in severity, and generally robust to our state by cohort fixed effects, putting in the lead for the reform and effects, again, are driven by states that are above the median. We look at learning disabilities. So what's going on with ADHD and learning disabilities as diagnoses in the US are going up over time. Janet Curry has a nice paper that suggests some of this diagnosis might be because of how reimbursements occur. So there's greater reimbursements for diagnosis for ADHD and learning disabilities. Again, we see increase in learning disabilities, diagnoses for learning disabilities by 1.5 percentage points, ADHD by 1.6 and 2.4 percentage points. But we do tend to have a significant effect on the trends. So we don't think we're properly accounting for trends in this analysis. Lastly, we wanted to just be very systematic. So we looked at all illnesses that were available in the NCHS over all 3 waves. So bone injuries kind of functions as our falsification test. So the RAND health insurance experiment says, you know, how bone injuries, the demand for medical care for bone injuries is pretty inelastic. You know, if you see your bone coming out, you'll go to the doctor. So this is something that, you know, because it's inelastic, you shouldn't see any changes. And we see solid zeros. For childhood diabetes, we only see effects in states that had a high number of physicians and for autism. So a big issue with this analysis is that it's a reduced form intention to treat study. You need a lot of observations. So we have about 270,000 observations. We do need to do some power calculations to see how much power we have to detect what effect size. So we do see some effects, increased diagnosis for diabetes and autism. So lastly, on health status, we generally don't see much on the subjective self-reported health status. The only variable where we do actually see some effect is on parents rating their kids' health as very poor. So one thing about this variable is it's been well documented that if you ask a parent how they rate their kids' health, most parents often use like very good and good. So if you were to actually look at the proportion, most parents rate their kids as having very good and good health. So very few parents actually say their kid has very poor health. So that proportion is very small. We see some effects on reducing the number of parents that respond to saying that their kid has very poor health. So the nice thing about independent practice authority is that unlike other government interventions in healthcare, there's no cost. It's a very cost-effective policy change. You know, just allow nurse practitioners to practice. Insurance tends to be very expensive. Allowing independent practice authority would be very low cost. So consistent with earlier studies tend to find, we do find some evidence that improves access to care. And as the prevailing body of literature shows, you also lower costs by allowing nurse practitioners to practice. And from a pure econ side, putting in restrictions to nurse practitioners when they're qualified causes a misallocation in the labor markets. And, you know, we have a social welfare loss by restricting them from practices. And from the health perspective, if nurse practitioners can help increase diagnosis of childhood diseases, this has very big implications for the health inequality literature, especially the race and income-based socioeconomic disparities. We feel like this is one way to kind of also maybe touch upon that, is by diagnosing and treating chronic illnesses earlier. All right, so just to recap, so we find a modest effect on improving access to care, only on mostly whether a child visits a doctor. We do detect big effects on the detection of asthma and learning disorders, but for the learning disorder analysis, we do see a time trend. So overall, we see our study as showing that, you know, allowing nurse practitioners independent practice authority improves diagnosis for children, doesn't indicate any harm, using the subjective healthcare variable. And so we think this paper adds to that very vast literature on nurse practitioners in saying that, you know, they probably should be allowed full practice authority. It'll be good from an economic point of view, and it'll probably be good from a health perspective. So the Hamilton Project had a report that said, you know, this is one issue, one urgent issue that we should tackle for inequality. And even the National Academy for Medicine, which used to be the Institute for Medicine, says that nurse practitioners should be allowed full practice authority. So the biggest thing we think that, you know, that is preventing this good idea from taking form is just, you know, public choice mechanisms, you know, political headwinds. So that's what we find. This is preliminary. I do want to kind of follow up on the suggestions made and fix up our analysis. So thank you again for providing this opportunity to present at this conference.
No problem. Thank you for presenting. We have about 10 minutes for questions if anybody has any questions. Okay. If not, I want to say thank you, Moiz, for presenting with us today. That was really nice of you to do. We absolutely appreciate having your paper here. If everybody will just give me a few more minutes of your time.